Welcome to Deuk Spine Institute. I'm Dr. Deuk Majan. Our patient is traveled from California. She has a couple of problems. One is a herniated disc at L5-S1 with an annular tear and discogenic back pain. The other problem is a piriformis syndrome with a torn muscle in her buttock. The piriformis muscle runs from the tailbone to the hip, from basically just to the side of the the butt crack over to the hip. I'm putting some numbing medicine right now to make things more comfortable for her. Shot. All right, very good. You can see on our x-ray, the needle is close to the spine. We're going to start with the Deuk laser disc repair, and then we're going to go to the piriformis release. This piriformis syndrome is common. We see it all the time, and we treat it all the time. And we used to treat piriformis with shot in the muscle, which is a pain management procedure. Unfortunately, it does not fix the problem. It only makes it feel better for a little while, and then, well, the patient comes back with pain. So we started thinking, what can we do to give permanent relief of pain? Turns out there's something called the piriformis muscle release. We did not create it. We did not dream it up. Somebody else did, and it's where they go in and do a myotomy. They're cutting the piriformis muscle. It's typically done by an orthopedic surgeon, and they have to literally slice you, and I'll show you the incision in a minute, but not right now. Right now I want to finish getting to L5-S1. All right, let's get an AP. Marker. Beautiful, perfect. We're at 5-1. We're right where we want to be. Incredible. So folks, we're fixing a bad disc right here. This is where most of her pain is. L5-S1. She has a tear in the wall on the right side. I'm going to go in and use the laser to clean the tear. She also has this muscle right here. It attaches from the sacrum over to the hip. Okay, it's fan shaped. It's muscle. It's called the piriformis muscle. Piriformis. I didn't name it. Anyway, that muscle has a tear right here. Okay. As a matter of fact, if you push right here, you can elicit horrible pain. Now, running between or down the tear is the sciatic nerve. So most orthopedic surgeons that do this will cut your buttock from here to here. Okay, and they will literally cut through your muscle like with a bovie. It's dead, and then they're going to find the piriformis deep to it and cut it. And it's a dangerous, bloody, painful procedure. So I developed a new way of doing it with a 4mm incision and release the tendon of the muscle off the hip. Pain goes away. Patients are happy. It's wonderful. It's permanent. So here we go. We're going to start with the disc surgery. She awake? I would like to try to do a discogram.
How are you doing? You okay? You okay?
Henry, let's show the audience how do discs cause pain. Nothing. I'll tell you later. Welcome back. At this point, we've done our discogram. And we are now getting ready to go past her facet joint. Jordan, show us the facet joint. By the way, her facet joints are not normal. They're abnormal. She has arthritis. You can see how big it is, how dark it is. Show us a more normal facet. 2 up. There you go. You can see the actual space right there, the white line. And then you can see the joint. Now look how much darker the 5-1 facet is. It's dark because it's sclerotic. Sclerosis is a thickening of bone. It happens as the body responds to abnormal stress at a joint. All right. Well, I am right at the back of her L5-S1 disc at this point. Shot. I can feel the herniation and the tear. Hold on. Let me feel it. Yeah, I'm bouncing on the herniation. Shot. Good. Yeah. Shot. Very good. We are inside the tear. We're inside the disc. L5-S1. You, by the way, if you, I don't know if Henry, did the audience get to see the tear?
Not with the discogram. That was in the middle of the.
Right, but they could see it at the bottom of the screen, right?
Yeah, they saw it.
But it's not a big picture, unfortunately.
No.
But you could still see there was a big tear in this disc. Big tear. It was literally a huge tear. I didn't think it was that big based on the MRI because the MRI doesn't show it to be that big, but with the discogram you can actually see the real size of it because the dye goes inside the tear and highlights it from the inside out. We need irrigation if it's not on. Looks like it is. We're good. All right, we are inside the L5-S1 disc herniation. Right there, the first thing we see is a piece of herniated disc that's degenerating. It's blue. Okay, right there. All right, so by the way, for those of you who join us quite often, look at this disc. It's a beautiful disc. The white stuff is annulus, torn. Thank you. If you have questions, feel free to ask me the questions. Again, we're starting with the laser on the disc, then we're going to move to the piriformis release. Now, the laser is the blue thing at 12 o'clock. It's got a plastic coating around the fiber. The fiber is glass, it's optical. This right here is scar tissue in the annulus. So you don't get that orange color without calcium. And the calcium is an indication this has been going on for a while. Usually a few years at least. Doesn't happen within a few days or months. But that's not normal. Any questions?
Yes, we have a question coming from Ping on Facebook.
Hi Ping, welcome.
Saying, hi Doc, is it only spine you treat or can you treat cubital tunnel also?
Hi Ping, I do cubital tunnel as well, but not often. I'm perfectly capable, highly trained. You're a martial artist. It would be like me asking you if you only do punches and kicks or can you also do blocks. You know, blocks are part of being a martial artist and they're an important part. Unless you're Bruce Lee and you're super fast, then you don't need to block too much. But the point is, treating cubital tunnel is in the neurosurgeon's purview of conditions that we treat, and I am a neurosurgeon. I'm perfectly capable of doing it. So yes, I can treat your or anybody's cubital tunnel. The first thing I would do is verify that cubital tunnel does exist based on EMG nerve conduct study that I perform or my team performs here, Dr. Damola or Dr. Patel. Second, I would want to verify symptoms you're having are coming from the cubital tunnel by a series of questions and an examination. Once I confirm in my mind that you have symptomatic cubital tunnel and that there's no doubt about it, then I would recommend surgery on the cubital tunnel. And I could perform that surgery. Happy to do it. But as I've said many times before, this is not McDonald's where you drive up and order a Big Mac. I don't have people just tell me, do my cubital tunnel surgery. I have to make sure that that's the right thing for the patient. Make sure you actually have cubital tunnel, that that's the cause of your symptoms. And that can best be done if you're actually here in Florida for me to verify that information. Okay? It's really hard to do over the Zoom, but I can try. Happy to try. If I can't, I'll tell you I can't do it over Zoom, but I can definitely treat cubital tunnel. Now, for those of you who don't know what cubital tunnel syndrome is, there's a nerve that runs, it's called the ulnar nerve. It actually runs down your arm, runs through the elbow, on the inner surface of the elbow bone of the elbow. Inner means medial towards your body, and it runs in a fossa or groove, like a valley in the bone. And what typically pinches it at the elbow is a muscle. That muscle is called the flexor carpi ulnaris, or FCU. That's the most common place the ulnar nerve gets pinched, in the upper extremity, but it can also be pinched in the wrist as it leads up to the wrist. I do ulnar nerve release at the elbow. I don't do it at the wrist. Orthopedic surgeons do it at the wrist. I don't. So, something to consider. This is all scar tissue right here. This indicates chronic inflammation. None of this is normal. None of this should be here. Tomorrow is Wednesday. We have clinic in the morning, I believe, and then we have... Yes, yes. It's just this, that's no different than a regular patient, except I have to read all the records and be familiar with them. And honestly, I don't care much for IMEs, but I'll do them if it helps somebody. Any other questions, Henry?
Yes, we have a question from Medic Alpha 21 on YouTube,
Okay, be happy to take the question.
asking, I have congenital fusion on my C6 through C7 vertebrae. It causes me pain and numbness slash tingleness. Can anything for me be done about that?
Yes, so first of all, welcome to our live stream. If you have a congenital fusion of 6-7, you have what's called a Klippel, spelled Klippel file, F-I-E-L, Klippel file syndrome. It's a fusion of bones in your neck that you're born with, has a specific name, Klippel file. And it does not cause any symptoms whatsoever. None. But what it does cause is accelerated degeneration of the disc above and below, which is what you have probably. And that's where your symptoms are coming from. So your symptoms are not coming from the fusion, they're coming from the joint above the fusion and below the fusion. Okay? That's important to know. And can something be done? Absolutely. But really what you need done first is an MRI review with me. So go ahead and get that scheduled. Submit your form. And I'll take a look at your MRI. And we will figure out why you're having your symptoms, okay? But it's not coming from the actual fusion. That's good. Yeah, we're almost done. We got about 4 minutes, 5 minutes max with this disc, Henry. And then we're going to move on to the piriformis.
Copy that?
I will say this, Dr. Berndes, there's an awful lot of scar tissue and calcium right here. You see all this? So although I say we're almost done here with this disc, I could be surprised. Because as we get closer to the area where there's blood vessels, we may get more scar tissue, which will make the surgery go slower. Yeah. This right here is the top of the herniation, right there. It's sticking out and it's hard. This is what's pinching on her nerves, going down her leg. And that thing is hard. Not hard like a rock, but hard like firm rubber. And the nerves are soft and delicate, remember. So, you know, something like that pushing on your nerve root, it's going to cause a lot of symptoms. Now, we're not going to get rid of 100% the herniation. We're going to get rid of hopefully 50, 60%. Surgery cannot get rid of 100%. There's no surgery in the world that can get rid of 100%. So we want to get enough to give the patient symptom relief. And that typically is going to end up being 50% on average. Okay? You need about 50% of that herniation gone. All right, you see everything okay? Berndes?
Yeah.
Huh? All right. This is it. This is really firm. I don't know if you guys can tell, but I'm digging the laser in and it's almost bouncing off this thing. But good news is this is the final part of the herniation right here. We're going to be done in a couple of minutes with this L5-S1. Then we're going to stop the broadcast. We're going to go to the piriformis and we're going to do a piriformis. Okay? The patient's asleep for this, but this is outpatient surgery. She's going to go home in an hour. Okay? Because we're making a tiny little cut in her back. And through that cut, 7 millimeter, 1/4 inch incision, we're using the tube and the endoscope to go in here and repair her disc. I'm going to try to pull out as much herniation as I can. Laser. Going to bring the laser back in. The grabbers are really bad at removing herniation because the herniation is so scarred up. The grabbers are better at removing what's called an acute herniation, which is a fresh herniation that's only a few days or weeks old. And that's one of the reasons why microdiscectomy doesn't work. It's because the surgeons use the grabbers. And you can see I stuck those grabbers in there, but they didn't do anything. That's because this is an old herniation. That's why microdiscectomy doesn't work. Is the grabbers are only grabbing fresh herniation, not the old stuff. You can't grab it. It's too hard to get out. And one of the things we do when we do a microdiscectomy to enhance the amount of herniation we get out is we use what's called a downbiting curette, which is a special tool that's metal, and it literally pushes the herniation downward and scrapes it and cuts it into more pieces. So it's easier to get it out. Berndes, you're making me tired, all this yawning you're doing over there. Is that you or the patient? Patient. There's a bone spur we just shaved off right here. You guys see that?
Yes, we do.
If you rewind and go back, you'll see a little sharp edge. Now, I shaved that bone spur off not because it was causing symptoms, but because it was keeping me from getting the herniation out. Right? It was blocking my laser. That's true of most bone spurs. They don't cause symptoms. I think 1 minute, Henry.
Copy that.
So, do we have any questions?
Yes, we just have one question coming from Samir on YouTube,
Hello, Samir.
asking, I see a lot of people suffer with vertigo or dizziness from neck discs. Please do something for them, Doc. And also, what is right and left L5-S1? Just curious.
Right and left L5-S1. I think there's a right side, a right foramen, and there's a left side. We are at the right side, the patient's right side. That's what we're doing now. If it says right and left, it means bilateral. It means we're doing both sides. Some patients need both sides of their disc fixed. Most need just one side, thank God. Otherwise, we'd be doing much more surgery. All right, we're just about done. So I want to point out to the patient that as she watches this video that was a bone spur, by the way. That's a bone spur right there. I want to point out that this disc is a lot worse in real life than it looked like on the MRI. And we see this from time to time where the MRI underrepresents the actual abnormalities in a patient. And there's two reasons for that. One, the MRI is not great at picking it up for various reasons. One of them is just it's a limitation of the MRI technology because the MRI is not a real picture. It's actually a composite of multiple pictures. Number two, the quality of the MRI is not good enough to pick it up. Or number three, the patient herniated more since I last saw them or I got their last MRI. And that's a real possibility. Okay? Real possibility. Very common. That's why we like MRIs that are recent. Okay? We don't like old MRIs. We're done. Go ahead and end the stream, and we'll start up again with the piriformis.
Copy that.